Hello, everyone, and a very warm welcome, a very good evening to all and everyone present here. So we are very happy to kick off with this session, and we have a series of webinars lined up, and we have our esteemed guest, Dr. Sanjay Kalra, who's with us, and our speaker from Kolhapur, Dr. Sneha Gavde. We have the pleasure to have both of us with us on this platform. So before we just push off, I would request Pratik, could you please put on sir's slide? Good evening, sir.
Good evening.
So we have the pleasure of having Dr. Sanjay Kalra among us today on this platform, where Dr. Sanjay Kalra and in association with Dr. Sanjay Kalra and our speaker for the day with Dr. Sneha Gaude. So before we push or we kickstart the webinar, I hand over the platform to Sanjay Kalra sir, who is an eminent endocrinologist from our country, based out of Karnal. And over to you, sir.
Thank you, Karan, and good evening, everybody. Warm greetings. Welcome to this program, our 9 p.m. program, where usually we speak about diabetes essentials.
Right.
But what we realized was that, of course, diabetes is important, but it's not enough to be glucocentric. You have to go beyond diabetes if you want to manage diabetes. And one of the things that we realized while speaking with all of you, while getting your comments, was that the simpler things tend to get ignored in our practice. One of the simplest things that you can do as a test is hemoglobin. And supposedly, one of the simplest diseases that we can manage, that we can prevent, that we can cure is anemia. Unfortunately, when we look at the data from NFHS, National Family Health Survey, we see that 67% of our children aged less than 5 years are anemic. 57% of our women are anemic, and even 25% of our men. And we have this abhiyan going on, the Anemia Mukt Bharat program, which had planned that by the year 2022, 18% reduction in anemia should be there. But when you look at the stats, what you see is that actually a 3 to 5% increase anemia has occurred since NFHS 4, that was done in 2015-16, and NFHS 5. So we have to fight anemia. Anemia is so important, hemoglobin is so important, it is too important to be left to any single group of medical professionals alone. All of us need to fight anemia. Therefore, we started Iron Talks. And for our first Iron Talk program, for me, it's a matter of pride and privilege to be able to invite our Iron Lady, Dr. Sneha Gadve.
Thank
Now,
you,
Dr.
sir.
Sneha, warm welcome. And Iron Lady of Indian medicine is what you will be known as now.
Thank you so much, sir, for that
Thank you.
kind introduction.
Yeah. Madam is Assistant Professor at D.Y. Patil Medical College in Kolhapur in Maharashtra. And one of the best teachers, one of the most popular teachers there with her peers and with her juniors as well. She has also worked at RCSM in Kolhapur. And she's a consultant physician at Excel Endocrine Center, Kolhapur also. She has been a sub-investigator, a co-investigator in many national and international clinical trials. And her area of interest is diabetes and thyroid, and of course, hematology, anemia. So, Dr. Sneha, you are the Iron Lady of Indian medicine, and we are on Iron Talks. Is every anemia iron deficiency? And when we encounter anemia or pallor in clinical practice, how do we assess it? How do we evaluate? Would you like to share some tips with us, please?
Yes, sir. We will take this all lecture in detail with our slides. But to begin with, we have to consider, obviously, we have to go for the diagnostic workup and also consider the etiological classification according to it. Yes,
Right.
sir.
So the platform
So,
is yours, madam.
yes, sir. Thank you. Just I couldn't share my screen from my side. You can just click the next button whenever I finish the slide. So
Yes.
I'll not tell the next button all the time. Uh, could you share the screen, sir, with slides?
Yeah, they'll be doing it.
Basu, sir.
So while we wait for the slides, Dr. Sneha, how frequently do you see anemia in your practice in the OPD and in indoor patients?
So mild anemia and moderate anemia, even severe anemia, it is very common in our daily routine practice. Obviously, we advise complete blood count for each and every patient, and according to it, we will have the further investigation. Some may need a IPDs also, so as to assess the patient.
Does any single day go by when you don't prescribe iron?
Yeah, it is like less common, but yes,
Mhm.
there are few patients whom we don't prescribe
Iron. But any
that
day in
also.
the OPD when you have not prescribed iron, is there any day that you have not seen a patient with anemia in your career in the OPD?
No, sir. It is like
Every
because the iron requirement is very much high,
Yeah.
even the iron absorption also matters. So, giving it as a supplementary drug is also better, always better to give.
There is this concept of hidden hunger as well. Hidden hunger means, like, if you have protein energy malnutrition, that you can see that the child is stunted, wasted, or there is protein malnutrition. uh, but hidden hunger means hunger of micronutrients like iron, like vitamin D. And so some of the hunger you can see in the OPD, and the rest you have to actually look for it, like anemia. So madam, the floor is yours.
Yes, sir. Thank you so much. And in this vibrant energy of Lord Ganesh festival, we will start with our first talk, that is assessment of anemia. We will please next slide. You can go for the next slide. The learning objectives will be seen on the screen. That is definition, clinical features, classification, lab workup, approach to anemia. Next. The anemia is coined in early 19th century, which means lack of blood. It is a Latinized form of Greek anemia. By definition, anemia is a condition in which the number of red blood cells or hemoglobin concentration within them is lower than the normal according to age and sex of the individual. Next, anemia is often back. Anemia is often defined based upon the hemoglobin level that is more than 2 standard deviation below the mean, where the men it is less than 13.5 gram per deciliter and women it is less than 12. Next. As we know, it is a serious global public health problem that particularly affects young children and pregnant women. As Sir said, but WHO estimates about 42% less than 5 years and 40% of pregnant women worldwide are anemic. Sir was talking about India. India is absolutely a developing country, and 89% of all anemia related disability are present. And most common is iron deficiency anemia, which remains as a dominant cause. In this global map, we can clearly see that the global map of prevalence of anemic patient, we can clearly see that India is a uh, highest prevalence rate for anemia. So, according to WHO, it has been categorized into mild, moderate, and severe anemia, and uh, it has been categorized with gender and pregnancy status also. Next. So, patient can present with fatigue, giddiness, shortness of breath, tinnitus, vertigo, generalized weakness, headache, palpitation. They can also present with jaundice, fever, melena, bleeding per rectum, abnormal menstrual irregularities. Hematuria can be present in some of the patient. It is also important to consider that the presence and severity of the symptoms in anemia depend upon absolute hemoglobin value, speed with which the anemia developed, and patient's comorbidities. On examination, we should see for the lower palpebral conjunctiva, where we can see the patient is having pallor, also bald tongue, and nail beds are also seen in anemia, and pale palmar creases. So, glossitis, angular cheilosis, chylonychia, lymphadenopathy, leg ulcer, puffiness of face, icterus could be these signs should be looked for. Even the patient can present with tachycardia, hypotension, collapsing pulse, hepatomegaly, splenomegaly. Signs of pulmonary edema could be there. Flow murmur, that is systolic murmur, is present. And in neurological examination, we can see for fundoscopy, deep tendon reflexes, and posterior column sensations. This is a typical phase of thalassemic patient, which is known as chipmunk phases. Next, in laboratory investigations, which is very common, we will first do a complete blood count and a retic index, iron panel, and vitamin B12 to reach for the specific diagnosis, liver function test, renal function test, USG abdomen pelvis for any other diagnosis we are looking for apart from nutritional deficiencies, and urine routine, stool routine, and stool occult blood, which is also important in looking for occult GI malignancies, especially in elderly patients. So this is a complete blood count report where we can see WBC count, hemoglobin levels, the RBC indices like hematocrit, MCV, MCH, MCHC, and RDW. MCV is mean corpuscular volume, MCH is mean corpuscular hemoglobin, and MCHC is mean corpuscular hemoglobin concentration, and RDW is red cell distribution width and platelet. So we are not dealing with WBC and platelet, but if at all three lines are affected in the erythropoiesis, we have to go for bone marrow examination, where the possible causes could be megaloblastic anemia, aplastic anemia, myelodysplasia, and hematological malignancies. The diagnostic framework for anemia, considering morphological approach, that is MCV, it is uh, divided into microcytic, normocytic, and macrocytic depending on the MCV values. If it is less than 80 femtoliters, we have to consider for iron deficiency, thalassemia like alpha thalassemia and beta thalassemia, and anemia of chronic inflammation. If it is a normocytic, that is 80 to 96 femtoliter, it has to be considered in a situation of anemia of chronic kidney disease, acute blood loss, in some patient anemia of chronic inflammation, sometimes hospital acquired anemia. Then high MCV, that is more than 96 femtoliter, is common with megaloblastic anemia. There are some non-megaloblastic causes also. Megaloblastic anemia, it is vitamin B12 deficiency and folate deficiencies, while non-megaloblastic anemia, it is associated with alcohol and liver disease, hypothyroidism, and myelodysplastic symptoms. In all these framework, hemolytic anemia was not considered as it may vary. It could be low, normal, or high MCV. For that, we can go for reticulocyte count. It is a non-reticulocytes are non-nucleated RBCs that still contain RNA and useful in determining response and potential of bone marrow. Normal range is 0.5 to 2.5%. We have to we have to calculate this retic index as follows. Next. So considering this kinetic approach, if we consider retic index less than 2, we can see it as a bone marrow is not responding appropriately, and consider these all diagnoses like anemia of chronic inflammation, nutrient deficiencies, hormone deficiencies, bone marrow failure like aplastic anemia, marrow infiltration, marrow suppression. While if it is hyperproliferative with retic index if more than 2.5 or 3, acute blood loss, trauma, GI bleed, retroperitoneal blood loss, uterine blood loss could be there, or hemolysis or hemolytic anemia should be considered. Next. This is a peripheral smear where we can see with an arrow that is a small lymphocyte that should be used as a reference to normal red cells. So in first it is microcytic hypochromic, second it is macrocytic normochromic, and third we can see it as normocytic normochromic. Even in this other picture, we can see a hypersegmented neutrophil on a peripheral smear, nuclei with 6 lobes. It is characteristic for megaloblastic anemia. And these are the few of the clues which we can find on the peripheral smear. The first slide showing cysgiocytes common with microangiopathic hemolytic anemia. Then second is pyrocytes, autoimmune hemolytic anemia, sickle target cells in sickle cell disease, bite cells in G6PD deficiency, and basophilic stippling in heavy metal poisoning. Next. So, an overall approach to anemia, we have to see is the patient bleeding acutely. If yes, then treat the hemorrhage and reassess for anemia. And if no, then you have to take a detailed clinical history, and also you have to advise a complete blood count with retic count and hemolysis lab. As we have discussed, decreased retic count, the probable diagnosis should be underproduction, and malnutrition and presence of chronic inflammation could be there. And in scenario of hemolysis, if we have advised LDH, it is raised, retic index is raised, indirect bilirubin is raised, and decreased haptoglobin will be there. And even blood smears may show microspirocytes and cysgiocytes. So we can say it as it is a probable hemolysis. Next. So this is a ion panel where we can see the ion transfer in total ion binding capacity, and transfer in saturation, and ferritin, where ferritin is an intracellular protein responsible for storing iron, and it is elevated in uh, inflammation. So it is a acute phase reactant. So while interpreting the ion panel in detail, how we can go is it is very important that microcytic hypochromic and low retic count should be there are few differential diagnosis for it. It is iron deficiency anemia or anemia of chronic inflammation, combination of both, and thalassemia. So in iron deficiency anemia, uh, here the transferrin saturation and TIBC are increased, while all the three iron, transferrin saturation, and ferritin are decreased. While in anemia of chronic inflammation, the you can see very clearly that ferritin levels are raised, while all three serum iron, TIBC, and transferrin saturation are on lower side and could be normal if it is in initial stage. And in case of iron deficiency plus chronic inflammation, if both go hand in hand, where we have some situations like patient is bleeding, having melena, and also having colonic cancer, then patient all three iron, TIBC, and transferrin are low, but ferritin could be low, high, or normal. In thalassemia, maybe because the iron stores are usually normal or raised, the total iron binding capacity is low, and the transferrin saturation is high or normal, and ferritin is high or normal. Yeah, thank you. So in underproduction, we have to go for iron panel and vitamin B12 and folate and creatinine. If it is low, we have to see for all these parameters like raised TIBC, and if it is there, then iron deficiency, anemia, and assess the diet, menstrual history, and symptom for malabsorption. Sometimes the patient may need colonoscopy or upper GI endoscopy. And if it is decreased or normal and increased ferritin, we have to consider for anemia of chronic inflammation, and also evaluate for occult malignancy, autoimmune disease, and chronic infection. Also, chronic infections like heart failure and diabetes also uh, can underproduction can happen in those patients also. Even creatinine also has to be done, and diagnosis for CKD has to be done in those patients. Then going to the decreased B12 and folate, we can diagnose as a megaloblastic anemia. Again, we have to assess the diet, B12 deficiency, and checking for autoantibodies, again intrinsic factor and parietal cells. If these vitamin B12 and folate are low normal, consider checking a methylmalonic acid and homocysteine for function of B12 and folate deficiency respectively. If on the smear, if blast cells are present, then bone marrow biopsy is to be done. If this panel and vitamin B12 all come normal, then we have to go for thyroid function test and liver function test. If that is also normal, then we have to consider for bone marrow biopsy. In hemolysis, we have to consider this direct comb test. We know that reticulocyte or retic index is raised. And if it is positive, we have to see for the smears and microspirocytes, and autoimmune hemolytic anemia has to be considered, and workup for that has to be considered. If it is negative and patient is having severe thrombocytopenia and smear shows cysgeocytes, then microangiopathic hemolytic anemia where sepsis or probable DIC, and if GI symptoms are there, consider HUS, and neuro symptoms are there, then you can see for thrombocytic thrombotic purpura. And in pregnant women, you have to differentiate between HELP versus DIC. Next. In this peripheral smear, if Coombs test is negative, we can have a various this peripheral smear is helpful. And if none of the findings are present, we can consider Coombs negative autoimmune hemolytic anemia and rare etiologies like paroxysmal nocturnal hemoglobinuria. This is a diagnostic framework for hemolysis where hemolysis could be intravascular or extravascular, and most intravascular causes are mechanical trauma, that is microangiopathic hemolytic anemia, that is disseminated intravascular coagulation, thrombotic microangiopathic thrombocytopenic purpura, hemolytic uremic syndrome. Other other it is transfusion reaction, paroxysmal nocturnal hemoglobinuria. In extravascular causes, it could be immune mediated, that is warm autoantibody and cold. In warm, it is due to lupus, CLL, lymphoma, and cold, it is due to lymphoproliferative disorders. And some of the drugs like beta lactam antibiotics are most frequently implicated. The intrinsic RBC defects like enzyme deficiencies, that is G6PD deficiency, hemoglobinopathies like sickle cell disease, thalassemia, and membrane defects like hereditary spherocytosis should be considered. Infections like malaria, babesis, and others like hypersplenism and Wilson's disease could be a cause in extravascular hemolysis. To determine the cause of hemolysis, we can advise these tests also, like hemoglobin electrophoresis, then family studies, osmotic fragility test, a G6PD test, and malaria parasite. Next. So, considering these prevalence of etiology, iron deficiency is very common and dominant cause of anemia. Coming to next is chronic inflammation, including malignancy, chronic kidney disease, multifactorial, including hospital acquired anemia, and unknown. Few of it. And then treatment of iron deficiency anemia. The balance of iron in humans is tightly controlled and designed to conserve iron for reutilization. Iron rich food should be included in each diet. Vegetarians, as they are at few disadvantage because food may contain phytates and phosphates, which can decrease the 50% of iron absorption, while non-vegetarians red meat is heme content is very much high, so that iron absorption is also high. Next, back. So, infant, children, and adolescent may unable to maintain normal iron balance because of the demands of body growth and lower dietary intake of iron. During last 2 trimesters of pregnancy, daily iron requirement increased to 5 to 6 mg, and iron absorption takes place largely in proximal small intestine and carefully regulated process. Next. So we have multiple preparations of iron, uh, starting from simple salts to complex salts. So most commonly we use ferrous fumarate, which is uh, slightly GI tolerability is good, compliance to the patient is good. Elemental iron or iron content in the ferrous fumarate is high compared to others, and usually we take this dose in between meals as guidelines. They have said that empty stomach we have to prefer, but as most of the patient have GI intolerability, we advise between meals for better absorption. The response to iron therapy varies depending on erythropoietin stimulus and rate of absorption. Typically, the reticulocyte count should begin in an increase with 4 to 7 days after initiation of therapy and a peak with 1.5 weeks. The absence of a response may be due to poor absorption, non compliance, and a confounding diagnosis. If the patient is not taking orally or iron absorption is not adequate in these patients, we can consider the parenteral iron therapy. Previously we used iron dextran, which has high anaphylactic reactions. Mm, so nowadays we have this iron sucrose or ferric maltose, which have lower rate of adverse effects, and we actually have to calculate this individual patient for amount of iron, where body weight is considered, patient's hemoglobin is considered, and extra of 500 to 1000 mg for iron store has to be done. So, to conclude, anemia is a global health problem. Etiological classification of anemia is important, and nutrition deficiency is one of the leading cause of anemia. And dietary intervention with oral or parenteral preparation should be used effectively to treat iron deficiency. Thank you.
Thank you, Dr. Sneha. Excellent presentation. And hemoglobin, iron, such a small element, and we never such a small protein, and we never realized that there are so many permutations, combinations when you diagnose anemia, when you evaluate anemia. Thank you for making
Yes.
things simple for us, and lots of comments coming for you, madam. Mr. Sharma from SGPGI Lucknow, greeting you, and Ajay Kumar Keshriji also greeting you, saying good evening.
Thank
Prakash
you, sir.
Jaiswal ji and Pranita Singh, excellent topic choice and excellent presentation, madam.
Thank you, sir. Thank Yeah.
One question is, let's talk about the OPD separately and maybe about the medicine indoor and gynae indoor separately.
Okay.
And for everybody who is logged in today, this is the first in our series of 12 talks, 12 iron talks. And by now you would have realized from madam's talk that even 12 weeks may not be enough to understand the entire uh, breadth and width of anemia. Bindu
Yes.
Bijlani ji also thanking you. And the question is, ma'am, let's talk about the OPD. Now, you've taught us how to evaluate clinically. We look for pallor, we look for fatigue. Uh, what proportion of your OPD patients with anemia would be having nutritional anemia, roughly?
In our scenario, where most of the patient come from rural areas, there are like almost 60 to 50 to 60% patients have nutritional anemia. We also advise them with deworming, and then we advise them with hematinics.
So hematinics would be the mainstay of treatment
Yes,
along with
yes,
deworming and T-helminthic, and it should
yes.
work in around 60-70% of patients.
Yes, oral preparation, most of the patients would tolerate. It is a better choice. It is affordability is also a question.
Hmm.
Some preparations come with ascorbic acid, but the cost again goes high. So we will prefer these salts to be advised, like ferrous fumarate.
Yeah. Also, so that question was coming from Chhattisgarh for you, from Dr. Anshul Singh, and you have just answered. And
Okay.
Dr. Anshul, our colleagues in the West, they just cannot imagine that in $1 American, in $1 US, you can give almost 1 month worth of iron, excellent quality iron to your patients. It's just $1 a month, the cost,
Yes, sir.
three
And
rupees per
also
dose.
we have to replace zero point 0.5 to 1 gram of the iron. Like after correction, also we have to store the iron stores also in the marrow. So we have to
Okay.
give extra doses also.
So first of all, iron to bring the hemoglobin up. First of all, to fill the stores in the bone marrow, then to
Yes,
improve the hemoglobin, and then to maintain it.
yes,
We
yes.
acknowledge a comment coming from Yugen Raoji that the slides were not clear. But Yugenji, if you can share your email ID with us in this in the comment box, Madam will be happy to share the slides with you. And any other questions also you can ask her offline. Just please share your email ID and we'll get in touch with you. One question coming from Dr. Anshul is, if a patient develops gastritis with iron, does it make a difference whether the patient is taking capsule or tablet or syrup?
In this situation, syrup and capsule would be advisable. Gastritis patient, so sometimes we will advise them to have this tablet with food, like
Yeah.
duration, taking a gap and then take the tablet, and then after 1 or 2 hours we can have that food.
So you
So
can
not on
try.
empty stomach, but
Yeah.
yeah.
One
So
more
that's
question.
it. Yeah.
Yeah. This is about hypothyroidism. So if the patient is taking thyroxine in the morning, what is the best time to give iron?
Afternoon or evening is the best time. Afternoon, preferably afternoon between the two meals, like between lunch and dinner, 4 or 5.
Yeah. And one question from Punjab, from Dr. Sanjeev Puri. Sir is asking, how do we test for anemia at point of care? Like, does it have to be a venous sample? Can it be a capillary sample?
Venous sample is better.
But for screening, sir, like usually capillary is done in the primary health centers, but certainly there is difference between venous and capillary, and what madam is saying is correct. And in
Yes.
fact, I think the changes in our epidemiology, like you see that anemia rate is going up or coming down. That is because the different studies have used
And
different methods.
even if we see the capillary hemoglobin, we will not get a full idea. We will get only hemoglobin concentration. We have to see for complete blood count, so that we need to do a venous sample. It is better.
Dr. Sanjeev Puri is asking, ma'am, if you are aware, Anemia Mukt Bharat Abhiyan. Are you aware of the details?
I'll go through now, sir.
That was Dr. Puri. That was planned that by 2022 we should reduce the risk of the prevalence of anemia by 18%. Unfortunately, it has gone up by 3% after COVID. So we need to start all over again. But
Yes.
let us take a new pledge today. Today is the first episode of Iron Talks, and this is our contribution to Anemia Mukt Bharat. So we'll
Thank
anemia free India. That is our contribution. I will be more vigilant from tomorrow onwards in the OPD. What I've learned from madam, I will be more rubro vigilant. That is an English word. Rubro means red. So I will at least look for pallor. I will look at everybody's
Yes,
tongue and
yes,
everybody's
yes.
nail beds and everybody's conjunctiva. That much I can promise. And then I will know when I have to give nutritional supplement or not. 70% will respond. 30%, let us say I'm not able to handle, then I will refer to Dr. Sneha or Dr. Puri.
Yes. Even a
Uh,
hematologist, yeah.
yeah.
In
One
few
question.
cases, hematologist help should be taken, sir. If
Yeah.
we consider a bone marrow biopsy, or if we are unable to reach the diagnosis, we have to do a bone marrow biopsy
Dr.
or
Vinay Desai has
aspiration.
a question. Uh, how much time does it take for anemia to appear? His question is, supposing somebody develops vitamin B12 deficiency today, so what is the order? Like, when will you get neurological symptoms and when will you get macrocytosis? When will you get anemia? How long? Like, what is the
So
hierarchy?
if we consider a megaloblastic anemia where cobalamin deficiency is there, cobalamin deficiency stores are very much high. 2 to 3 years we will uh, not require the replacement. But the folic acid is, or folate deficiency is very much common. It has to be replaced every monthly. So folic acid is also essential part, so that all foods are fortified with folate. That is one thing. And in for iron, there are stages for iron deficiency. To go into a microcytic hypochromic or piculocytes and anisocytes picture on the blood smear, the whole of the marrow stores and all those are gone till then. So to pick up at a early stage, we can add the hematinics. That is one option. But most of the patient which we see in our OPD, most of the patient with anemia, we can the patients have already landed in microcytic hypochromic picture.
Yes. And Dr. Sneha, many more questions coming for you. You answered this question from Dr. VK Goyal, can we take iron in between meals? So you have answered that. Sir is also asking, Dr. Goyal is asking, how much time does it take to increase hemoglobin by 1 gram, supposing it's iron deficiency? So how do we counsel the patient?
Usually, sir, the requirement is around 200 to 300 grams per day, which we give as a hematinics. Usually advise 2 to 3 times a day, but we don't advise that much. Once a day tablet. So 3 months at least we have to give. Newer formulations which are coming, like ferrous pyrophosphate, those increase the hemoglobin levels at a much faster level. So
So,
depending on the iron salts, we have to see.
and in general, you can counsel your patients that it will take about 3 weeks for hemoglobin to begin increasing,
Yes,
minimum.
yes,
Yeah,
yeah,
because you tell them the endocrinology also, like the iron is going to go there, but iron is not going to make the hemoglobin immediately. There is a life cycle also for the hemoglobin to get formed.
yes, yes,
Then erythropoietin is also required to use that iron.
yeah.
So, so many thank yous coming for you from Dr. Anshul, Dr. Bhupender Singh, and also greetings from a person named as Love Humanity, which is very nice. And Dr. Sangmesh Chavanda helping us out, reminding us about drug interactions. Avoid taking calcium and iron together. Thank you, sir, for
Yes,
sharing
yes.
that. Also, check drug-drug interactions with the other things, especially if you are treating infectious disease. Supposing you are treating mucormycosis. So, ma'am, would you like to show more light on shed more light on this mucormycosis, iron, anemia?
It comes under the anemia of chronic inflammation. So we have to see for the ferritin levels, as we have discussed. And if the patient is not tolerating oral, and we need to have, as we know that hemoglobin is an oxygen carrier. So if patient is having severe anemia, we can go for red cell transfusion if the patient is having severe anemia. If not, we can have always an option of parenteral iron therapy.
That will also help in case your patient is very sick and you feel
Yes,
that
yes.
improving
And
the hemoglobin, yeah,
yeah,
will improve overall outcome. One tough question coming from Dr. Anshul. Hemoglobin is normal, but MCHC, mean corpuscular hemoglobin concentration, is lower than normal. Any other test that we would want to do? Will we want to treat, or we can tell the patient to relax?
hemoglobin is low. No, actually,
Normal.
this
Hemoglobin is normal.
classification is based on MCV levels. So we have to look for MCV level.
Okay. So
So
it will
that
be
is the more,
MCV,
yeah,
physiological. So
yeah,
MCV rather than
physiology.
MCLC. And another question is, okay, this is from Nitin Narulaji. This is subclinical iron deficiency. So what he is asking is, my hemoglobin is normal, but I got iron studies done and iron levels are low. So should I take iron or not?
Yes, you have to take. So,
And because iron will impact not only the hemoglobin, Nitin, it will also impact your cognition. Supposing hemoglobin is normal, but iron is low, you will find that your body and brain both will be suboptimal. Dr. Anshul is
even
practicing.
with serum iron, we have to look for the total iron binding capacity and all the iron panels also we have to look. Only serum iron looking,
Won't work.
it is not sufficient. We have to look in
Ferritin
a
and
complete.
transferrin saturation. These are most important.
Yes.
Lots of tough questions. So this question, I don't know if anybody knows the answer to it, but Dr. Anshul says he is practicing diabetes in Chhattisgarh. He is seeing a lot of patients with vitamin B12 more than 1500, more than 1700. Even I see them in practice. So how do we suspect clinically? And what do we do if vitamin B12 is high?
As I said in the clinical science, sir, we have to, in severe megaloblastic anemia, we have to look for the neurological examination in detail. Um, Next is all these symptoms like even in megaloblastic anemia, the peripheral smear is important, and all three blood cells lines would be depleted, like pancytopenia picture, like there is ineffective erythropoiesis. So all three line would be affected in megaloblastic anemia. So pancytopenia picture could be there.
And if B12 is very high, then usually it is because of exogenous reasons, like maybe patient is taking multivitamins, too much of that.
Yes, yes,
We can counsel the patient that it is a water soluble vitamin and it will vanish. So you just don't take any vitamins for a few weeks.
yes, yes, sir.
One more tough question from Dr. Bhupinder Singh: intrinsic factor deficiency in megaloblastic anemia. So you had talked about the workup of megaloblastic anemia. Would you want to share a few more clinical pointers?
Sir, in this, what sir has said, that intrinsic factor deficiency, we can consider it in pernicious anemia. So there are few tests to rule out this autoantibodies against intrinsic factor. If the absorption, when we take oral vitamin B12, if absorption is not there, then we have to look into these things. Yes.
Uh, and questions keep on coming. I am so pleasantly surprised. Such a small atom, iron, and such a small protein, and creating so much interest. Dr. VK Goel says folic acid is already present in the hematinics. Do I need to give an extra tablet, or is the combination enough?
uh, Daily requirement is 5 to 15 mg, so it will be suffice.
Fine. Yes.
Yeah.
And one question, let both of us answer. But Pam, pehle aap answer karo. Question is coming from uh, Chhattisgarh again. Please suggest one good trade name for iron. Oral.
As as we know that capsule Vitcofol is really a good drug which contains ferrous fumarate, also the elemental iron and GI tolerability, as they have some uh, the nanoparticles are there, so GI tolerability is totally good for that.
I will support Madam with that wholeheartedly. Not that the entire Iron Talks agenda, if you see, it is not geared towards one particular preparation. It is, we are talking about anemia, about rubro health, about hematinic health. But
Yes,
actually, the preparation is very good. It is so economical, and in today's world, when you have so much of polypharmacy, the cost is so much. This 3 rupees capsule Vitcofol actually doesn't hurt anybody, and the
yes,
nanotechnology actually allows for better GI tolerance.
yes, sir.
Two questions. This is hemoglobin is 12 in a diabetic lady. MCH is always on the lower side, but you have answered that already, that we need the MCV. So if you
Yes.
can, if the MCV is normal, then perhaps we can relax.
Yeah. Yes, sir.
Praveen
And
Sutarji,
even we can go for a iron panel where we have to see for ferritin levels as it is raised in diabetic patients also. So we can see for the iron panel also.
and anemia of chronic inflammation you should rule out in long-standing diabetes.
Yes, yes.
Praveen ji and Tahir Shah ji, thanking you for excellent presentation. Dr.
Thank you, sir.
Mohammad Suhail saying good evening, and he says I joined late, but madam, parenteral iron, what are the indications? Intravenous iron.
GI intolerability, then considering patient's condition, if patient of like poor iron absorption, if the patient is having, for example, like elderly patient not having good tolerability, and like plummer vincent syndrome, so those patient doesn't have a good oral absorption, so we can consider a parenteral iron preparations.
Dr. Javed Iqbal Khan says, if I give 1 unit of blood, 350 ml, how much will the hemoglobin increase?
It will range from zero point 0.5 to 1
So not more than that.
gram.
So if
Yeah,
hemoglobin is 6 and you
yeah.
want to bring it up to 10, then you need minimum 4 or 5 units of blood. Dr. DG Parmar
Yeah, but we have to reassess with a complete blood count after maybe after 2 days or something. After giving a pack cell volume, just don't give a daily dose of pack cell.
yeah,
Yeah,
whole, and whole blood also will come with its
until
own.
and unless if there is a acute bleeding somewhere, then we have to consider 1 or 2 packs of red PCV transfusions.
But Dr.
We have,
Javed, I would like to thank you for asking this question, and I will tell you the reason why. The reason is that we created a comprehensive agenda for anemia, and that comprehensive agenda means 12 weeks. And now suddenly I've realized we have not put your topic in the agenda. So we acknowledge questions about hypothyroidism, about other things, and they will be covered sooner or later in the coming weeks. But we need actually a separate iron talks just on maybe critical care management, when to give blood, when to give IV
yes,
iron. But
yes,
thanks for
yes.
asking the question. Dr. DG Parmar has a much simpler question, though it is a very non-Kolhapuri kind of a question. And he says, what are the vegetarian foods that are rich in iron?
You can go for tofu, then spinach is a rich source. Then any food which are cooked in iron
Vessels.
utensils like jaggery, poha, those are also fine. But in diabetic patients, we don't usually advise those. So they can go for lentils, spinach, broccoli. All these are vegetarian foods which are rich in iron.
There is one question on diabetes. Let me take. So supposing patient is not well controlled on 20 units of basal, then if you shift to premix, the minimum you will do is 30 units of premix, because that 30 units of premix contains 20 units of basal. But patient was not very well controlled, so we need to increase further. So maybe from 20 basal, I will shift to 20 premixed in the morning and 20 premixed at night. The dose will be similar for analog and human, but not the same. Analog, you will start same with breakfast and lunch, 50-50. If it is human insulin, you might want to do 2/3 and 1/3, like 25 in the morning, 15 at night. But analog is much safer. So 20-20 in this particular patient. Stop the sulfonylurea, continue all the other drugs. Uh, and Dr. Javed has another question. So, madam, you mentioned that if you give oral iron, it takes about 3 weeks for the hemoglobin to go up. But if we give intravenous iron, like ferric carboxymaltose, then after how many days does the hemoglobin begin to rise?
Uh, it has a quick response.
Within
Uh,
4 to 5 days, yeah, Dr. Javid,
yes,
the patient
yes,
will feel a kick
uh,
actually.
yes.
And you can tell the patient
Exactly.
actually
I
that
don't, but it is in a clinical practice, we have seen that it gives a very much better response, quick response. It is there with ferric carboxymaltose.
and the word I use in the OPD is kick actually, because it actually gives an anabolic kick to the patient and patient feels happy. But it is good idea to say 4 or 5 days, 1 week, and give a range. If you say, 3 hours and 43 seconds, then patient will come back at 3 hours and 44 seconds and begin fighting you. So give a range to the patient, but it is quick.
Yes.
Madam, more and more regards and thanks for you for having taken up such a difficult topic, but more and more questions. So dinner is going to be delayed. H. pylori infection. This is a question from Dr. Sharad Sonawane. H. pylori and iron deficiency. So is it common, and do I treat with oral or with intravenous iron?
H. pylori infection usually causes cobalamin deficiency and folate deficiencies. Iron deficiency also could be, as we know that in India, the iron deficiency is also a nutritional cause
Mhm.
for anemia. We can go for oral therapy also. We can see the response, how the patient is responding. If patient is not responding, we can go for these IV preparations.
But first oral, okay. And one more question is vitamin B12 deficiency in a person who is taking metformin and also a proton pump inhibitor like rabeprazole, pantoprazole. This vitamin B12 deficiency in patient on metformin, should I give oral or sublingual or injectable vitamin B12?
Um, Preferably, the B12 which we advise is intramuscular, which has highest absorption capacity. Next to it, we can also advise sublingual and oral also if the patient is not uh, considering for injections. So we can have any options. Ultimately, we have to get that replenishment in our body.
Is also a good idea to give the choice to the patient. Some people like injections, others don't like, and
Yes.
or depends upon the kind of staff you have also. So like in my OPD, when we have to give injectable testosterone, so I have, first of all, I have to see who is on duty amongst my staff. That 4
Yes.
ml of oil injection is not easy to give, and then we tell the patient, this is it. And if you want to get injected at home or from a chemist, be careful because you might land up with an abscess. Dr. Sharath points out that in his practice, hemoglobin is normal in many people, but iron is usually low. So their iron has to be given.
You
Uh,
can, in these patients, you can first advise iron rich food, as I have mentioned, and then you can see for the response. If obviously tablets are very useful, but all everything is normal and only serum ions is low, then we can advise them with diet iron rich foods.
Dr. Singhai is engaged in a lot of public health awareness in Bhillai. And he says, Madam, what is your clinical message and what is your public health message for albendazole? So, how should we advise to patients and their families? And what message should we give to the public at large for albendazole?
Albendazole or deworming is should be there, especially in low socioeconomic conditions. We have to advise with deworming. So clinically also, see, we can advise tool routine, we can have a microscopy report, and then we can advise, or directly we have to take one tablet of albendazole, and the further we can treat with nutritional deficiencies. So that is
Lot of
one thing. On public basis, like it is a huge, it can't be considered from my side. Let's see like how it works clinically, at least I can decide. Yeah.
And is this correct, madam, that if patient comes to me in the OPD and I advise her albendazole, I should also tell her to deworm the entire family, including people who are entering the kitchen, like cooks and domestic helps? Is that correct approach or is it wrong approach?
Not necessary. If the patient is having symptoms, then only we can
Okay.
have that option.
So we stick to single patient. We
Yeah.
acknowledge the questions coming from Dr. Akanksha, Dr. Javed, Dr. Sanjeev. All the questions are related to intravenous iron and also to blood transfusion. Uh, and what this tells me that anemia is much, much bigger than I had thought and than what FDC had thought. So certainly we will add one program on IV iron per se.
Yes, sir.
But ma'am,
Yes.
if you could take some of these questions, it is nearly 10 p.m. now.
Yes, sir. Yes, sir.
Dr. Javed Khan says, what is the onset of action of packed cell transfusion versus parenteral iron, IV iron with carboxymaltose? Onset of action.
Paxil iron, we have a direct heme, so we will have that advantage with Paxil volume. And it is always advisable in acute blood loss with severe anemia with hemodynamically unstable patient. We always go and prefer for red cell blood transfusion. While the parenteral therapy, we have to go. We just can't correct. We have to see whether there is iron deficiency for that patient or any other diagnosis is there. Could be anything like megaloblastic anemia or myelodysplasia or anything. So we have to first rule out whether the patient is having iron deficiency at first point, and then we have to go for parenteral iron therapy.
Another question, follow up, is that overall it is difficult to achieve good compliance with oral iron, though of course now the quality of preparations has gone up markedly. So, and you've also talked about how to choose a good preparation. Do you have any personal experience with liposomal iron?
No, sir.
No, I also don't
Yeah.
have.
Okay.
Slides, we got an email from Dr. Satish Kumar Jain, and sir, the FDC team will reach out to you. If you can share the name of the city where you are working, that will help us reach you faster, sir. This is to Dr. Satish Kumar Jain and Dr. Bhupender and everybody else who wants the slides. If you could share the city that you live in. Dr. Akanksha Tyagi says, okay, so this question, we need a calculation, but let us take a weight of 50 kg, 60 kg. Hemoglobin is 8. And how many ampules of ferric carboxymaltose do we need to give? 500 mg.
Age is
Age they have not mentioned. Hemoglobin of 8 and
okay.
average weight. Let us just take 50, 60 kg as average.
Okay. Could be around 1200. So 5 to 6 ampules could be
Yeah,
ultimately like one ampule contains, I think, this Vitcofol S, where we have this iron sucrose. It contains 300 mg per ampule. So we can advise 3 to 4 ampules for that patient. But we have to obviously calculate and then give. I have just told like.
right. And okay. Karan, could you repeat again? Is it 100 mg per ampule? Uh, I think it is 100 mg, 100 mg
100, okay,
per
100,
1 ml. Yeah,
okay.
100 mg per 1 ml of IV Vitcofol. Dr. Khan raises a very, very important point, and that is called rubrovigilance also, pharmacovigilance. He says that no drug is absolutely safe. That we will agree with you, sir, fully, and thanks for raising this. When you give iron sucrose, the risk of transfusion reaction is 3%. When you give ferric carboxymaltose, it goes down, but it doesn't go down to 0. It's 0.8. And all parenteral iron transfusions must be given in hospital where facilities for
Yes.
management are available. Let me add to that, sir, where the staff is also trained, because all the
Yes.
staff will not be trained. It might be the OPD nurse who is injecting IV iron, and she is not so fast because she is not used to critical care. Ma'am, Dr. Sneha, in your experience, in your clinical practice, have you ever experienced any iron transfusion reaction, and what was the outcome like?
Iron transfusion reaction was very low at our place, but uh, blood transfusion reactions are there,
Quite common.
but in a form of patients getting chill, like not
Shivering.
very serious.
Hmm.
Anaphylaxis is also not common, but maybe at some places they have this anaphylaxis, and so the warning has been given. So
Frequently.
anaphylaxis, previously the iron dextran which they used, it was very much anaphylactoid, but nowadays the newer preparation it is less.
One question from Dr. Girish Gesota. Dr. Girish, sir, if you allow, in a few weeks' time, we will have a special program on iron anemia in children. This will be done by Dr. Mudita Dhingda Dua, and she will talk to us in more detail about how to calculate doses for pediatric patients. So if you allow, we can take it then. And thank you, Mr. Basu, for correcting us. It is 100 milligram in 5 ml vial. So thank you for sharing that information.
Yes.
But Dr. Sneha, it's been a great day with you, and it's been a great beginning to Iron Talks. And
Thank
people
you,
are
sir.
thanking you. Bhupender Singh ji lives in Delhi. Thanks for being with us. But I would like to thank everybody who has logged in. It is Sunday night. There is a cricket match going on. It's a festive season. It is Ganesh Puja. And what I would request everyone is, let us allow Dr. Sneha also to take time off for the family and for Ganesh Puja, and everybody as well. Dr. Sneha, entire okay. One more comment from Dr. Javed. Dr. Javed, ये तो बताएं आप रहते कहाँ हैं? It is really nice reading your points. So what Dr. Javed is teaching us is that sucrosomal or liposomal iron is the safest. Okay, it has stomach bypass effect. It does not irritate the stomach mucosa, but the liposomal iron directly gets absorbed in the duodenum. So thank you, sir, for adding to our awareness.
Thank you, sir. Thank you.
Madam, the example of liposomal iron is Witkofol hemoglobin, Witkofol
Oh,
HB. That is the
yes,
preparation.
sir. Yes, sir. It is ferrous pyrophosphate. Yeah, but the technology which they have used, I was unaware. So, yeah.
So Witkofol HB is a good drug for that.
Okay.
Madam, people listening to you from across India, it is more than 1 hour now. And our talk today was Iron Talks. So, madam,
Yes.
two questions for you. Let me ask both together. The easy one
Yes,
is,
sir.
how does it feel to be called the Iron Lady of Indian medicine?
Sir, like it is a pleasurable moment for me. You have given me a big opportunity to speak in front of uh, all these people, and I feel this privilege. Thank you so much, sir.
Thanks is due from our side, madam. And second question is, what take home would you like to share with everybody who is watching you today?
We can like these are few minor things. We see it as anemia, but usually we have to look for iron deficiency. We should correct it. Nutritional deficiency, any form, if it is correctable, if it is in our hands, we have to correct those things.
So I think that call for action is what we all take home and we take to our OPDs, to our indoors tomorrow.
Thank
Dr.
you so much.
Girish Kisota says the answer, sir, is ferrous iron fumarate, which iron salt is preferred in patients with comorbidities. So
Yes,
fumarate is the
serous
safest.
fumarate is good.
And we are really, really thankful to Dr. Javed Iqbal Khan. Daksab is from Srinagar, from Government LD Hospital in Srinagar. Thank you, sir, for enriching today's webinar. So it is a complete Kashmir to Kolhapur program, entire India watching. With this, I would like
Thank
to
you,
thank
sir.
everyone for being with us. Thank you, Dr. Sneha, madam. Thank you once again.
Thank you,
Now
sir.
we understand. Now we understand why you are so popular amongst your peers and your juniors and students. Thank you, madam.
Thank you, sir. Thank you.
And I'd like to request Mr. Basu from FDC to join us, please.
So I would just only say it was a very fantastic program to begin with the Iron Talks of 12 episodes, and I'm sure you have already done a lot of hard work in terms of arranging the topics. And with the suggestions coming up today, I think we can further enhance the content of the topics in coming weeks. But at the same time, I would like Dr. Sneha Gadve to start the session with a very content-rich preparation today, and Dr. Sanjay Karya for a wonderful moderation. With this, we thank all our viewers. Good night. Jai Hind.
Jai Hind.
Thank you, sir. Thank you so much.